The Society for Vascular Surgery, under the leadership of Richard Cambria and Peter Glovitsky, has initiated an audiovisual interview project with the pioneers of vascular surgery. This is a part of an effort by SVS to develop archives to preserve the history of SVS as well as vascular surgery as a specialty. A committee was formed called the History Project Work Group, chaired by Dr. Jimmy Yao, with Norm Rich and me as members. Cal Ernst has served as our consultant. Because of the workload, an expansion of the committee was needed. William Baker, Mark Eskandari, Walt McCarthy, William Pierce, Melina Kibbe, and Peter Lawrence were added. Since the initiation of this project in November of 2011, we've interviewed some 50 leaders of vascular surgery. SVS recently has recommended that these interviews be extended to honorary members of SVS as well. Today, we will be interviewing an honorary member, Professor Jonathan David Beard. Thank you for agreeing to this interview.
You're very welcome.
Let's start with your early years. You were born where?
A town called Chelmsford in Essex, not far from London. Essex is a little bit of a joke town. It's where people with poor taste come from.
And the date of your birth?
23rd of October, 1955.
Tell us about your parents.
My mother was a nurse.
Right.
She trained at the London Hospital in the Mile End Road in the East End of London, which was a pretty rough area of London at that time, just after the war. And my father was electronic engineer, worked for Marconi's, who then were taken over by GE. And he was a backroom boffin in the war, developing surface-to-surface communication systems. He still wouldn't tell us exactly what he did. It's covered by the Official Secrets Act. And then after the war, he worked for the Admiralty Surface Weapons Establishment down in Portsmouth.
Were these great influences in your early life?
I was always planning to be an electronic engineer. I had that planned for a long time, and my parents were keen for me to do medicine.
Really?
Yeah, I think partly because the pay for electronic engineers at that time wasn't very good, and they thought.
But the pay for physicians was better.
Yeah. But maybe I should have founded my own electronics company. Then I could have done really well. Anyway, it's been a sideline interest of mine for many years, and it's influenced my career.
Now, tell us about the structure of your early education. As you know, the educational system is a bit different in the United States versus England. Tell us about your early education.
Okay, well, my parents, I'm one of 4 children. I'm the oldest child. My parents actually paid for me to go to a primary school, which is a private school, as opposed to a state school. That's from the age of 5 till 11. And then they ran out of money, so I was the only one who went. But that got me a scholarship to what's called a public school.
Right.
And in England, a public school is not a public school.
It's the private.
It's a private school. So
makes sense.
Yeah, of course. But I had a scholarship to that school, which meant that my fees were paid.
Terrific.
Otherwise, my parents wouldn't have been able to afford it.
When did you start seriously considering medicine as a
I guess halfway through, when I had to choose my A-level subjects, which are what you need to get into med school. So at that point, I was pushed quite hard to do the subjects required to do medicine.
And your medical education, was that in conjunction with university, or was it separate?
Yeah. So in the UK, you go into med school directly from high school.
Oh.
So
okay.
I was quite young for my age. I was one of the youngest in my class. So I actually started med school at the age of 17.
Wow.
Which most people are 18. But that's the English system. You go into med school, you don't have to do another degree first.
Was this a
which is
guy's?
good. Which is good thing. It has good things and some bad things. Good thing is you get qualified very quickly.
Right, right,
You're qualified by the time you're 22, 23.
right.
Um,
Now, this was at Guy's Hospital?
Guy's Hospital, yeah.
And then you went as a registrar?
Well, a senior health officer first.
Right.
I did anatomy demonstrating at the Middlesex Hospital in London. I was keen to stay in London because I was also playing rugby football at that time,
Right.
and I wanted to stay in the team, so I had to stay in London. I played rugby because I was good at it, but also a lot of the senior residents were good rugby players as well. So it was there was a little bit of an advantage in terms of promotion if you were a good player.
Now, after you had been a registrar, then in '87 you got a master's in surgery from Bristol.
Yes.
This was after you already had gotten an appointment as a consultant?
No. So it's way before. So I did my own rotation really. I moved around the country and decided where I wanted to go. That's not very common these days. Most people do a rotation which is based around one teaching hospital,
Right.
and I think it was really useful to do my own rotation. The real reason for doing my rotation like that was because I wanted to carry on playing rugby,
Right.
and to a semi-professional level, I guess. And one of the best teams in the country, in the UK at the time, was Bath Rugby Club, which was based down in the West Country. So a friend of mine and I, who was also a junior surgical trainee, both went off down to Bath to play rugby, but also to work at the hospital. But the work at the hospital was secondary. The real reason for going was the rugby.
Now, another certification you received in 2004, a master's in medical education
Yeah.
from Sheffield.
Yes.
Was this related to rugby again?
No, that I'd given up by then. I gave up when I realised my ribs weren't as flexible as they used to be, and when I broke a couple of ribs, I decided that was it. So from Bath, I went to a small town called Cheltenham, which actually was really started my career in vascular surgery, because there was a senior surgeon there called John Fairgrieve, who isn't well known, but actually he was one of the first people in the UK to start doing infrainguinal bypass. And he took himself off to France and went to see Cartier and brought back a set of original Cartier strippers for in situ bypass. And he had a big practice, even though Cheltenham was a relatively small hospital. He had a reputation which meant that patients were sent to him from a long way away. Because at that time, really, infrainguinal bypass wasn't regarded by many people as a viable procedure. And that set me up for moving to Bristol to work with Mike Horrocks and Roger Baird, who were in Bristol. And that's when I did my master's. And my master's in surgery was based on assessing the compliance of veins and arteries, with a view to trying to improve vein graft outcomes.
Is this, and we'll get back to that
Yeah.
in a moment, because that's something I'm very interested in. Now, this completed your surgical training and training in vascular surgery?
No, that was my research, and then I had a phone call from a chap called Peter Bell
Oh, yes.
in Leicester,
Right.
saying, "I've heard you're doing good things down in Bristol, and my the lectureship in surgery, is coming up, and I'd like you to apply." So and then I went. I was interviewed. I got the job up in Leicester, and that was my last registrar post before taking up a consultant appointment in Sheffield.
Right.
Yeah. Peter Bell says he didn't think I was fully trained by the time when I got the job in Sheffield, but.
Now, did you have the option of going into an academic direction versus a private practice, or was this obligatory?
Well, in the UK, 98.5 or something percent of doctors work for the NHS. It's a monopoly employer.
Okay.
Very, very few doctors are to go into pure private practice. A few aesthetic surgeons maybe, and a handful of private primary care physicians, but everybody works at the NHS,
Okay.
so it's not an option. And whether or not you get a post at a university teaching hospital, i.e. a big city hospital, or whether you get a post at a district general hospital, tends to be often related to your academic performance in the past. So, and my academic track record was sufficient to get me that job.
Now, let's move aside for a moment and talk about your personal life. You got married to Claire at what point in your training here?
Well, Claire's my second wife.
Oh, okay.
So we were married 5 years ago.
Oh, terrific.
Thank you.
Do you have any children?
Yeah, I have two from my first marriage,
Right.
and she has two from her first marriage. So we have four between us.
Ah,
Yeah.
terrific.
Yeah.
Military service?
No.
Didn't have to.
No, it was no longer compulsory. It was. I did. We had the school I went to was a school that had a lot of sons of serving officers. It was a school that was a boarding school as well. I didn't board, but it was a boarding school, and about a good third of the kids there were from military families who were overseas, and they had a very big cadet force. I don't know if you have cadet forces.
Yes.
Yeah, so I was in the cadet force, and I actually had a commission lined up in the Royal Artillery, just in case I didn't get into med school. But I got into med school, so I didn't need that.
Fortunate.
Yeah.
Let's discuss your honors and achievements for a moment. This is quite an impressive list. Your memberships in the Royal College of Surgeons, in the Vascular Society for Great Britain and England, as chairman of the Joint Vascular Research Group from 2001 to 2004, and some of your present appointments being professor of surgical education now at the University of Sheffield since 2007, and the chair of Education and Training Committee of the Vascular Society since 2009, the chair of surgical education in the Royal College of Surgeons in 2012, currently. And the president-elect of the Vascular Society of Great Britain and Ireland, as well as the editor now of the Journal of Vascular and Endovascular Surgery. And the list goes on and on. This is very impressive.
Thank you.
Further, your publications cover a very diverse group of topics with some 170 scientific papers, 6 books, 44 chapters. How did this happen to you?
Well, I think I'm a workaholic. My wife would say so.
Really?
Yeah, I mean it's a big part of my life, and but I've always been interested in lots of areas. So I think that's really important, not to focus too much on one particular area.
So you think this is hard work that paid off?
Yeah, it was all done out of hours at night. The European Journal in particular was a huge commitment.
Right.
And I did that for 15 years, from a junior editor right through to editor-in-chief. But that was, most evenings, a couple of hours a week, a couple of hours at most evenings a week.
Right.
A lot of work. Yeah.
Any tips on time management, which is what this all revolves around, isn't it?
One of the things I was strategic about doing was ensuring that if I was doing something like a degree, my master's, I made sure that every dissertation I had to write was published as well. I made sure everything was counted twice.
Right. Right.
Which I think is a strategic way of doing things. I was always very careful to get home for meal times with the kids. And then I'd work later after that. I could go back to work later on at night or early in the morning. So I think it's important to make time for kids. I probably didn't make enough time for my first wife, which was probably a mistake.
It's easy to look backwards, isn't it?
it is. Yes, yes. But
Now, with all this series of tremendous success,
Yep.
did you have any failures? Any disappointments?
No, I've been extremely fortunate in my career. I mean, I've had some really good mentors. Mike Horrocks down in Bristol, and then Peter
Right.
Bell in Leicester. Roger Greenhouse has been very encouraging with the European Journal.
Right.
I've had some fantastic colleagues both in Europe and Australasia, Canada, and North America who've been very encouraging to me. And that's been a really fantastic. I've come into vascular surgery at a time when it was a really moving
Right.
in lots of exciting directions, and I was
Right.
very fortunate to be involved with that. And going into medical education was a really good, in retrospect, was a very good plan.
Right.
Even though it wasn't really a plan at the time, it just happened.
You think that most of these things just happened with you, or did you move them in that direction?
Well, I do. I tend to have 5 or 10 year plans. I don't
Right.
like doing the same thing for more than 5 years. I guess I'm good at I'm good at developing. I'm good at the R&D stuff.
Okay.
I tend to leave the implementation to someone else. I guess that's what I'm good at.
Would you mention some other things about mentors
So,
that you have had?
yeah, I think one of the things I'd advise any junior trainee would be to to find a good mentor.
Crucial.
That's crucial. Yeah, and somebody who's prepared to stick with you even if you may be
Right.
somewhere else in the country. Somebody you can come back to repeatedly to ask for advice.
Let me ask you what your favorite vascular operation might be.
My favourite vascular operation, I guess, definitely not femdistal bypass.
So that's at the
As
bottom
one
of
of
the list.
As one of my trainees called it, a femorodismal bypass. I probably carotid endarterectomy, I
Right.
guess, would be my favourite.
Very elegant
Yeah,
procedure.
I don't like doing any operation these days unless I can teach.
Okay.
And I do a lot of operating now with a colleague. I think that's the way forward for a lot of major
Right.
procedures, is to do them together. Infrainguinal bypass with two of you there is a pleasure,
Yes.
as
Yes.
opposed to a penance.
Yes. Now I'd like to move to some focal areas that perhaps we could talk about a little more in depth. The first is the Cutler's Prize that you won for basic science regarding circulatory dynamics, wall compliance, and blood flow. I'm very interested in this because this would apparently provide you with an element of measuring resistance in the vascular bed and perhaps predict whether a distal bypass might be successful or fail.
Yeah.
Now, how did you come to this?
Well, this came out of the work I did originally with John Fairgrieve in Cheltenham, and then I went to Bristol and carried on my research with Mike Horrocks, and we were looking at to see whether you could relate the wall compliance with histological changes, both in arteries but also in vein grafts, and to see whether in situ veins had better compliance than reverse veins. That was one of the key questions to ask. And it was really seeing, the question was whether you could influence compliance
Right.
of a vein graft to improve the patency. So it comes back again, this is where my interest in electronics comes in, because hemodynamics is very like electronics.
Right.
The components of a hemodynamic circuit are the same as an electrical circuit. So you've got impedance, you've got capacitance, you've got resistance. And I did a degree at Guy's Hospital in physics applied to medicine, working with a guy called Ray Gosling, who was one of the pioneers of hemodynamics, working with MacDonald, who wrote a seminal textbook about blood flow and blood flow dynamics. And that's where my interest in hemodynamics came. So what we were trying to do is see whether we could influence the active components, because inductance and capacitance are active components, as opposed to resistance, which is a passive component. And the compliance and inductance of a circuit will depend upon the frequency of the pulse wave you're putting into it.
Now, were you able to apply this in the operating theater?
Well, we did various different we tried different methods, including vein cuffs, constraining the graft inside prosthetic materials to try and see if we could alter those dynamic components. But what we found was that although they were significant, the thing that really mattered was the DC resistance of the runoff bed,
Right.
and that was what really mattered. So, if the DC resistance of your runoff was too high, then the graft wasn't going to work.
It's going to be doomed.
Yes. So then I went. The resistance machine I made was just a simple way of measuring the resistance of runoff, and we can all do it with a syringe. If you've done enough operations, if you inject saline into the runoff, not too hard, most experienced surgeons will know whether it feels okay or not.
Okay.
And the machine was just a way of giving a number to that.
Right. To give some more objective data.
Yeah. And it was calibrated in peripheral resistance units, which is
Right.
how it's measured.
Now, the second focus area I'd like to address is the endovascular management of aneurysms.
Yeah.
Tell me about your work there.
Well, I realised that I was worried about the introduction of new technology without much regulation around it, I guess.
All of us were worried to death.
Yes. Having seen what happened with laparoscopic cholecystectomy a few years before. So I was in a position, because I was already in the council of the Vascular Society, I was in a position to help set up a registry, which was called the RETA Registry of Endovascular Treatment of Aneurysms, which we managed to get every unit in the UK signed up to contribute to that registry. And that registry helped to inform the design of the EVAR-1 and EVAR-2 trials.
Right.
So what's remarkable is that the results of the registry were almost identical to the outcome results of the EVAR trial. So even though it was only a registry, the morbidity, mortality results, the complication rates were almost the same.
How did you find candidates for the endovascular graft as far as who was a candidate with regard to the length of the neck? Was this by CAT scan alone, or?
At that time it was by CT scanning.
Now,
yeah.
today,
Yep.
how do you make this determination?
It's still by CT scanning,
Okay.
but of course we didn't have reconstructive, the 3D reconstructive techniques
Right.
we do now.
How much of a neck is required now,
Well,
in your view?
we're pretty conservative. We only 40% of the patients in our unit
Right.
get an EVAR.
That was my question.
All the endovascular repairs in my unit are done by the interventional radiologists. So we have very good interventional radiologists. We work very well with them. So they make the final call, but they are probably more conservative than I am in terms of, agreeing to do an EVAR.
Is this all in the operating theater?
No, we have an endovascular suite with
Okay.
with sterile theatre air
Okay.
facilities.
Right.
So, but the good news about the fact that we are so conservative is that our endo leak rate is extremely low.
Right.
We just don't see many.
Tell me about if a ruptured aneurysm comes in,
Yeah.
would you consider using an aortic stent graft for that?
Well, yes. Well, there is a trial going on in the UK of that called the Improve trial, which Janet Powell has been running. I was very keen to be involved with that trial, but we've had real problems in being engaged in that trial. And the reason is that our EVARs are done in the endo suite, and the endo suite isn't part of the main theatre complex. And the anesthesiologists are unhappy about doing ruptures in the endo suite because it's not part of main theatres. So we've actually not been able to run the trial because of the anesthesiologists.
But for a ruptured aneurysm, would you still have to have a CAT scan to measure the neck?
If they're going to go for endo, yeah.
Right.
Sure, yeah.
Now, you've done quite a bit of work on open carotid surgery versus stenting. Would you speak to that?
Yes, I've been involved in the trial committees of the Cavitas trial, which was one of the first trials of endarterectomy versus stenting, and then the International Carotid Surgery versus Stenting trial. So I've been on both those trial committees with Martin Brown, who works in London, linked with Peter Rothwell.
Do you have a view on this as yet?
Which is best?
Yes.
I've done the meta-analysis work, and if you're talking about a symptomatic patient, then carotid endarterectomy has a lower rate of stroke and death than a carotid stent for a symptomatic patient, and even the CREST data shows that. I think that the closer you get to the index event, the more risk there is. I can't help but think that an event in the last week or so probably means you've got an unstable plaque in your carotid artery, and I think if you've got an unstable plaque, the best way of treating it is with an operation, not with a stent.
Speaking of stents, how can you reconcile putting a balloon into a stenotic plaque, mashing it down, and then applying metal cage? How can this work? I realize it works, but how do you reconcile this from a hemodynamic and a physiological?
I can't, and that's why I think when you're talking about asymptomatic disease, then it seems to me the evidence suggests that a stent is probably as safe as an operation. And the reason is that it's asymptomatic. If it's asymptomatic, you've got a stable plaque, and there's much less risk of the plaque being disrupted and embolizing. But we in Sheffield we have Sheffield is one of the two major centres for doing carotid stenting in the UK. Newcastle's the other one, with Samira MacDonald. Trevor Cleveland leads our stenting programme. He's a supremely gifted endovascular interventionist, and if I needed to have a carotid stent, he'd be the person for me to do it. And all the patients are considered for both, and we have a significant number of patients who are clearly best treated by a stent, or who choose themselves to have a stent. We give them the options, and bottom line is it's a patient choice. I've had an opera singer who said, I understand there's a higher risk of a stroke with a stent than with an operation, but I don't want to have an operation because I'm worried about my voice.
Right.
That's fine, that's their choice.
Makes sense.
But the acute ones more commonly get an operation than a stent. I think that's how it should be. Anyway, it's a nice operation.
Elegant operation.
And it's a great operation for teaching trainees.
Right. And it's tried and true.
Yep. And the other thing I think that was missed from all the carotid trials, is that you look at the CREST trial, and only a selected number of centres were encouraged to participate, and then of the centres that were encouraged to participate, 40% were deemed ineligible because their results weren't good enough. So you were really selecting centres, and all the stents were done by attendings.
Right.
Well, I can tell you that almost every carotid endarterectomy that I've ever done that's been part of a trial has been done by my resident, under supervision by me.
Right.
And you're not telling me the interventionists let their residents do
No,
them.
no.
So it's, I think carotid endarterectomy is relatively easy to teach, whereas I think carotid stenting is an extremely complex procedure with a very long learning curve.
Right.
I think that's an important point.
Let's speak for a moment about your hobbies, which obviously reflect the well-rounded man. You already mentioned rugby football,
Yes.
but you haven't said anything today about sailing and
Uh,
skiing and
yeah.
perhaps singing and gardening.
Yes.
Tell us about your sailing.
Well, the sailing goes back a long way. I used to sail as a kid, and then I sort of gave it up a bit when I had children, because my one regret is ending up in Sheffield. It's about the furthest place you can get to from the sea in the UK. So there are a few ponds around, but it's not the same. So I gave it up, and so I've really only come back to it since my kids were have got a bit more grown up. I have a catamaran, a 16-foot fast cat, which I keep at my down in Cornwall, where I have a little cottage, and that's a very scary boat. It's
Fast.
25 knots, yeah, and it's very wet and very fast, and crashes very, very quickly.
Not,
Most
but
of my children have got the scars to prove it.
but not pole over.
Oh yeah, pitch bowling, yes.
Pitch
that was,
bowling.
pitch bowling, yeah. Yeah.
Now, you've also done a bit of racing sailing.
Yeah, I do some offshore racing
Right.
with another vascular colleague of mine called Andrew McKerbin, who has just finished as the Commodore of the Royal Ocean Yacht Club, Rorke, who organise all the offshore races, including the Fastnet race. He's actually been over here to visit the New York Yacht Club when he was the Commodore. And he has a boat down which is kept on the south coast in Cowes, which is the sort of mecca of English sailing, I guess. So I crew on his boat. He pays for the boat and I crew. It's the best way of doing
Sounds
it.
like a good arrangement.
Oh, it's a very good arrangement.
Now, these are opinion questions
Yes.
that are very brief, perhaps, but nonetheless, we want your strict opinion. Is vascular surgery seen as an independent surgical specialty in the UK?
Yes, it's become an independent specialty this year.
Now, the training for vascular surgery, modern training, in the United States has changed quite a bit, and such that now you can even get a 0 to 5 program which allows a medical graduate to start vascular training straight away after medical school without general surgery background and training. Tell me, is there such an arrangement available in England?
No, we will be doing vascular surgery as a separate specialty from next year, and that'll be 6 years. As opposed, before it was 4 years of general surgery and 2 years of vascular.
Correct.
4 plus 2. It's now going to be 6. But all surgical trainees in the UK do 2 years of basic training first.
Okay.
So it's a 2 plus 6 program.
Wow.
And the 2 is now. I went to the program directors meeting in Chicago last year, vascular program directors, and I got the feeling that there was worry that 5-0 wouldn't give them enough general surgical basic skills.
Perhaps not.
They all have to do 2 years of basic surgical skills, and they have to do a basic surgical skills exam at the end of the 2 years, and then they are selected from core surgical training into the specialties. So it gives you a second chance of checking that they're progressing.
Right.
And so most specialties in the UK think that that's a much better arrangement than having a recruitment straight out of med school.
Interestingly enough, the most popular program that's being sought after now by the trainees is the 0-5.
Yeah, is that because they think they'll get qualified quickest? Or?
Correct.
But my worry is that a lot of them will say at the end of it, I don't think I'm ready.
Right.
I think they'll want to go and do something else.
I share that concern with you.
Yeah.
Is there a certification test for vascular surgeons in the UK?
Yeah. We have a new specialty exam, which will be parallel to the other specialties. So we're a new specialty, we've had to set that up, but it'll be the parallel exam. So it'll be called the Fellowship of the Royal College of Surgeons, VASC, and that'll be taken towards the end of the training program. It's an exit exam.
Now, the European Board of Vascular Surgery qualification for vascular surgery in countries that, is this just in countries that belong to the European Union?
Yes.
Okay.
Yeah.
And if that exam is passed, does that mean that you have reciprocity among
No.
the other nations?
No.
No. Okay.
The European Board would like that. It was set up really as a minimum standard for especially for smaller countries that didn't have their own vascular
Okay.
exam. So until recently, quite a few of the British trainees did it because, of course, there wasn't a British vascular exam. So quite a lot of trainees do both. There's one country, the Netherlands, that regards the European exam as its takes it as its national exam.
Okay.
But the European exam is necessarily has to have a standard which might not be quite as high as some of the
Okay.
others.
Now, regarding endovascular technology, and this is certainly, even though established, certainly new technology in many areas. What kind of initiative can you bring to vascular surgery to ensure that they're properly trained in endovascular? Is this just hands-on, or do you use a simulator? And also, as a corollary, now that more and more cases have been done by endovascular techniques, how do you preserve training in open techniques?
Yeah. Right. Well, simulation has come in significantly in the UK, not as much as in North America and Canada, and there's a good reason for that, which I'll explain. But so there's certainly a concept now that if a simulator exists, if a suitable simulator exists, then a trainee should have to demonstrate a level of competence on a simulator before they're allowed to do it on a patient. So that's certainly true for laparoscopic, and it's certainly true for endo. All endoscopic and endovascular for that matter. I'm not so sure that simulation is very useful for more advanced and more complex procedures. Certainly open, it's just not there. And the advantage we have, and we have a lot of technology. I've spent a lot of time doing the research and development, which is my master's in education, into assessing trainees in the workplace.
Right.
So in the operating theatre, both in terms of their technical skills and in terms of their non-technical skills, their situational awareness, their communication skills, their decision-making, leadership. And we have very valid instruments for measuring those skills. The thing we can do in the UK, which you I think have a problem with in America, is that we can say to the patient that the resident is going to be doing the operation, and I will assist the resident, but I will not. I will assist them as an assistant. And when they're ready to fly solo, they'll do the operation. I'll scrub in and assist, but I won't direct it in any way unless I have to, for patient safety. And that's signed off openly. That's how it works. Whereas I think you have a bit of a difficulty with that concept.
Somewhat,
Yeah.
but not entirely.
No. So it means that we can sign people off very openly as able to do the procedures.
Now, when the SVS and ISCVS merged into one vascular society, in your opinion, was that merger valuable, or do you think it harmed international exchange?
No, I think there's too many vascular societies around the place.
Okay. I agree.
And some of them are better than others, and I think bigger societies can talk with a stronger voice, both to governments and healthcare providers. So I think the bigger the better, quite honestly. I think
How might we improve international exchange?
Well, I think the World Federation is doing quite a good job in that respect. I think the concept of a federation of individual vascular societies seems a sensible way of moving forward, rather than having yet another international vascular society. So I think the federation idea is a good idea. What I would like to see, what we're working on, is an idea of a common some sort of common curriculum.
Right. Right.
I'm working with the Australians on that.
Interesting.
So that we could have, not enforce it, but people could see what the common curriculum was.
Some guidelines.
We could share learning resource. So if the SVS has got a good portfolio of training videos for vascular procedures, then let's make them available to other vascular trainees around the world. And there must be some way of having a reciprocal login system so that your trainees can share the resource that we have in workplace-based assessment, and our trainees could share your resource in terms of other things. So if you like, a website which would allow trainees to access learning materials wherever they were in the world, because online learning resources are incredibly time-consuming to design and deliver.
But once there, they can be extremely helpful.
Of course, yes.
Yeah, the SVS has also initiated an international scholarship program for young vascular surgeons abroad. This allows them to attend meetings for SVS and also the opportunity to attend at least 2 or 3 other academic centers. Would you sponsor or encourage one of your trainees to apply for a scholarship of this sort?
Absolutely. I worry that the current generation of trainees are being produced who have only been trained in one place,
right,
and only in one way. And one of the really nice things about my training system, which I sort of designed myself, I guess, was that I've worked in 4 or 5 different vascular units, and we have quite a regular exchange program with Toronto, and our trainees have come back with a whole new skill set and a whole new view on vascular surgery. So I would encourage trainees to spend at least a year, if not more, in somewhere else, preferably in another country, to see how it's delivered elsewhere. It's very important.
Partners in industry are very important for the development of technology, certainly by academic centers. Can you address the issues of conflict of interest in Europe? How was this addressed?
Well, I've not personally had any conflict myself, so it's maybe easy for me to say things. It's a difficult tension, isn't it? Because the companies are the ones who are taking the financial risk in terms of developing stuff, and they need to get their money back. But I do feel that there's a slight difference in the way that new drugs are developed and the new devices are developed. You would not get a drug accepted for sale without a randomized trial.
In the UK?
Anywhere.
Okay.
You just wouldn't get it accepted. And the idea that devices should be different from that, I find a little difficult. And I fully understand that it's not possible sometimes for numbers and various other reasons to do randomized trials. But I do feel that if you're not going to have a trial, then there should be some form of registry. And the registry should be independent of the company. Registries, companies running their own registries, I have concerns about.
Right.
So I think the problem is then who pays for the registry,
Right.
Do the companies pay for it, or should it be part of the national regulatory framework?
In your opinion, what is your view on the leadership role of American surgery in world affairs regarding vascular surgery?
Well, that's a leading question.
Yes, it is. But we want your opinion.
Yeah. Well, the United States and North America as a whole have been pioneers in a vast areas of endovascular intervention, partly because you have the numbers and partly because you have the money.
Correct.
But it's interesting that often the ideas come from elsewhere originally.
Right.
Well, endovascular parodi.
Right.
If you go back far enough, I have a picture of showing Michael DeBakey standing in Lisbon with Dos Santos
Yes.
in being trained in, and of course, Lisbon was the Portuguese were the first to do angiography, and Felix Iscott debatably was the first person to do a carotid endarterectomy, and the first person to do in situ bypass was a Frenchman.
Right. Right.
And most of the anastomotic techniques were originally developed by the French. So
Well,
I think what the US is good at is picking up these ideas and running with them, and making them into and turning them from ideas into reality.
we also have the FDA.
You also have the FDA.
In terms
Yeah,
of training
yeah.
foreign graduates in vascular surgery and fellows in vascular surgery from Europe, the issue of medical malpractice has severely limited our visiting surgeons to scrub in the operating room. Do you have similar problems in the UK?
With visiting surgeons,
Right, to allow them to scrub.
yeah. It's not too much of a problem for there is no problem for European trainees because
Right.
they all have equal opportunities. We still don't we don't have a problem with American, Australasian, Canadian trainees. There's not a problem with them. It is up to the individual hospital to decide whether a surgeon can operate. There's not a national regulation.
Okay.
So I guess we don't have as much problem as you have. That's one of the reasons I think that some of our trainees have gone to Toronto rather than coming to
Right.
to the US.
I'm as transparent as a window pane with that question.
Yes. Yeah.
Traditionally, we've seen very great English vascular surgeons as honorary members of SVS, to include Felix Escott himself, Peter Martin, and many others, including you. Somehow, this appears to be on the decline. We've been very honored to have you as an honorary member. Would you consider making recommendations for other British vascular surgeons for honorary membership?
Another leading question.
Yes, of course it is.
Yes, I think so. I think
You don't have to give me a precise answer now.
no names now.
No.
No, I think so. I think it's increasingly difficult for the current generation of surgeons who have a much more constrained and confined training program, which has great strengths, but it also has weaknesses, which makes it more difficult for people to choose a rather alternative or different career pathway. And it's often those differences and those nuances that allow people who have particular enthusiasms to stand out.
Right.
So I think we uniformity carries some risks. And
Very diplomatic, very diplomatically stated.
I don't think there's enough. I don't think we do enough to encourage eccentricity anymore. Safe eccentricity. I reckon.
Now, I'd like to ask you for a few more opinion questions, more oriented to the U.S.
Yeah.
As you know, healthcare systems in the United States have become a political football for various reasons. And despite our recent election, I still believe this will remain quite a controversial issue. Do you believe we've lost our way?
My personal view is that that a mark of a civilized country is one that has universal access to healthcare. So I'll put that one down to start with.
Okay.
The question is, what does that mean, and whether a country can afford it?
Correct.
So with the level of what you mean by healthcare.
Right.
So I think that's the $64,000 question,
Right.
isn't it? Can you afford it?
Quite difficult.
And I certainly think there should be a fail-safe net that allows anyone
Right.
to get access to healthcare that they require for life or survival, without having to ruin their family.
Correct. I agree.
But if you come to some other things which are more lifestyle choices, then I think If you can't pay for it, then that's your problem.
Right. Now, going back for a moment to
Don't buy the new car, buy the new operation.
Right.
Whatever you want.
Going back to endovascular surgery, I know that you're involved in some trials to address this, but what is your personal view of the longevity of these new procedures? Will they have the durability of an open procedure?
Well, I think that's the major. That's the reason why a lot of these trials need to be taken out much longer than they have. That's why, for instance, the EVAR trial has decided that it needed to relook at the data. We heard this morning about the heparin bonded graft trials that need to be looked at longer. And of course, everybody wants to have a defined short-term outcome for their trial so they can get the results published quickly. But actually what you need is a longer-term outcome. And that's again where registries come in. So I think the two are integral. I think what you need is a system where you have a registry initially maybe to inform the design of a trial, then you have the trial, and then you have another registry. You don't say at the end of the trial, okay, it's a free-for-all. Everybody should, everything should, it's post-market surveillance. You do the same for a drug.
Right.
For a new drug, there'd be a period of intensive reporting of any adverse outcomes. So, the answer is I don't think endo has good long-term outcomes as open for most procedures. It's getting better all the time.
Technology is still advancing.
It's still advancing. Yeah. But that's why my particular unit majors still in open repair. We have trainees sent to us specifically for training in open techniques, and I think within a few years, 5 years, we'll actually be having trainees wanting to have open fellowships.
Correct.
But there's not going to be many trainers left.
So you shan't retire at this point.
I have to hang on for a while.
And a final question for you.
Yep.
Do you have advice for young vascular surgeons?
Well, it's my profound regret that I've tried to encourage women trainees. When I was the program director, I encouraged a number of women trainees to come into surgery, but every one of them has voted with their feet and gone into some other area of vascular, some other area of surgery other than vascular. And it's still tough in terms of the call.
Yes.
In the emergency work.
Yes.
And the only way you can square that is by having very big units. So, and that you're really looking at regional units dealing with 3 million population. To have a big enough unit, where people where women in particular, who can square it with having a family. Right. I think it's very difficult for them. So that's one thing I'd like to improve is the quality of life, I guess, for vascular surgeons. So my advice would be get a good mentor.
Absolutely.
Get engaged with a research program, as many different aspects as possible. Don't put all your eggs into one basket. Major big time in getting procedural experience, and at least 1 year, if not more, in another unit somewhere else. And make sure you end up in a large centre where you have plenty of other colleagues with a rota that's going to be sustainable until you retire, because these guys are going to be working till they're 70 plus, to pay for our pensions. And I don't know about you, but I wouldn't want to be doing a 1 in 4 or on call for ruptured aortic aneurysms until I'm 70. It's hard enough now, and I'm only 55.
Dr. Beard, thank you very much for this wonderful interview.
You're welcome.